Good afternoon or good evening, depending on where you are. I'm Heidi Stephany, a clinical professor at the University of California, Irvine, and the Children's Hospital of Orange County. I'm the pediatric director, as well as the associate resident director at UCI. And today I'm going to talk to you guys about pediatric urologic trauma emergencies. I have no disclosures, and if you are a pediatric urologist, you'll soon realize that you most likely will not either. So today we're going to look at the diagnosis and management of GU trauma. We're going to cover the entire tract, so the upper tract down to the lower tract. And I'm also going to give you some practical applications for the GU trauma consult, which I did pester my fellows as well as residents to give me some tips. So as I've heard, kids are not little adults. There is more than just a significance in anatomy, but also physiology and development. So kids are actually able to compensate much better than adults are physiologically. So what that means is that they can have significantly rapid deterioration when those compensatory mechanisms fail. So in kids, you really can't go by hypotension because this is actually quite a late sign of hypovolemia in children. Kids can actually, it's estimated they can maintain their blood pressure until nearly 40% of their blood loss volume. So as I always, it seems like every July or August, I get a frantic call from one of my new residents on pediatric rotation telling me that an infant's heart rate is 150 and the blood pressure is extremely low. But again, this is just a nice chart that I like to tell people to just take a picture of so you can keep it in your mind, or if you have a resident guidebook or anything like that, always something good to have and let them know, obviously, the significant differences. Most of the trauma that we see in pediatrics is blunt. It's the cause of 90%, and 90% will also have coexisting injuries, such as the thorax, ribs, spine, pelvis, and extremities. Different than adults, hematuria is not exactly reliable in assessing the location as well as the severity of the injury. So you really have to kind of keep an eye on that because the amount of hematuria can be significantly disproportionate to the severity of the trauma. And I should mention, I'm going to go over questions at the end, if that is okay with everybody. So most blunt injuries, what do we think of? So falls is a huge one. Also motor vehicle crashes. ATVs are something that I think we see more and more, and sadly see younger and younger kids on. Bike crashes, sports injuries, which is what I think people typically think of. And also we do see some physical and sexual assault. Penetrating traumas are less common, but we can see some pretty interesting things in pediatrics with falling on certain objects, as well as gunshot and knife wounds too. So in 2014 and then updated in 2017 for urotrauma. While these are not specific to pediatrics, they essentially the same principles will apply. Now there can be some differences when it comes to radiographic evaluation, but we'll go into that further. So first and foremost, you want to ensure that you have an accurate and efficient evaluation of all of the GU structures. You want to remember to preserve GU function whenever possible. I don't think urologists ever have a problem doing this. Familiarize yourself with both open and minimally invasive techniques for hemostasis and or urinary drainage. You want to make sure you have the right diagnosis as well as intervention. And again, we cover, you guys know what urology covers, but this is our whole aspect here. So the European Association of Urology actually has a significant amount of pediatric guidelines. I encourage you all to take a look at that, as I was doing this when I was working on this talk. So in 2020, their recommendations came out with all recommendations, but again, talking about imaging. So any child with a blunt or penetrating trauma with any level of hematuria, especially when the mechanism is known, such as a deceleration trauma, direct flank, or a fall from a high height. Also, they recommend CT scan, rapid spiral CT with imaging for diagnostic and staging purposes, which is also similar to the adult guidelines. Most kidney injuries can be conservatively managed. And then obviously surgical intervention is needed in cases of hemodynamic instability and a grade 5 renal injury. So most renal trauma is secondary to blunt trauma, and the kidney is the most common GU organism to be involved in trauma. They can, renal injuries account for about 10 to 20% of blunt trauma, Now, while it's somewhat controversial, it's thought that the pediatric kidney is more susceptible, and there's a couple of reasons for that. It's thought that it is protected by a less immature or more immature pliable thorax and less ossified rib cage and weaker abdominal muscles, making it more susceptible. Also, relative to the rest of the child's body, depending on the age of the child, the kidney is much larger, and there's less fat, and the kidney sits lower in the abdomen. Now, don't forget pre-existing renal abnormalities, which oftentimes you can see, sometimes as well. And so you kind of have to be thinking about your pediatric, even if you're not a pediatric urologist. But in kids, we certainly see it about 3 to 5 times more common. So I like this quote of being diagnostically aggressive while surgically conservative when it comes to pediatric renal trauma. I think more and more this is true also in the adult realm as well. But you have to make sure you have an accurate diagnosis to be done in a timely fashion. So let's not forget our basics. So the ABCs. First, make sure your patient is hemodynamically stable. Then obviously a history and physical, as this can also help direct your imaging. Urology is not usually the first consult that the trauma team will place in pediatrics or in adult world. So again, they may have already had some of the imaging, but it's important for you to understand what the mechanism was, and maybe that would understand the reasoning for why they, what imaging they did. So again, as we discussed, there's a poor correlation with hematuria in the pediatric world and renal injuries. So some have shown that 2/3, even with a grade 2 or higher of renal injury, can have a normal urine analysis. Also, you really can't go by the hypotension as much and the degree of injury. As we discussed, kids have a higher sympathetic tone, so they can maintain a much higher blood pressure at much more blood loss than an adult can. So before you see that hypotension, you're going to see a decrease in their CBC. So in adults, any hemodynamic unstable patient and hematuria has imaging. All penile, abdominal, and pelvic trauma also gets imaging. When you're looking at blunt trauma, the mechanism once again does matter. So if they had a significant deceleration, like a motor vehicle crash, or fall from a high velocity, so a fall from like greater than 15 feet, if they had an injury to a strike to the abdomen or flank. Also, if there's any other spine, pelvic, or femur fractures, rib fractures, obviously you need to be considerate of that. Bruising, always look on the flank. I know sometimes it's not the easiest thing to do. Also, look for any signs of peritonitis. Again, don't forget your general surgery trauma that you had as an intern. Gross hematuria as well will also get you an indication for imaging. And then microhematuria. So it's greater than 50 RBCs for blunt and greater than 5 for penetrating. And also if they also have shock. So again, we talked about a triphasic CT scan with delayed imaging is the most sensitive test. With no drainage films, obviously, you may miss an isolated ureteral injury. While that is rare, but you can miss an isolated injury. So you also want to look, and we'll discuss this a little more, but looking at the ipsilateral ureteral location and then whether or not it has contrast, because that may be a predictor of when or when not to proceed surgically. An IVP, while this is rare to use anymore, a single IVP in an unstable patient who is in the emergency room may need to be done. And they always seem to ask about this on in-service. So IV injection of 2 mils per kilogram of contrast with an abdominal x-ray 10 minutes after it's injected can help you determine. And the most important thing we're looking for there is to see whether or not, is to see whether or not they have another kidney, just in case you have that kidney. So also the focused assessment or a fast ultrasound, more and more children's hospitals are wanting to focus on this significantly, where we are going to, oh, I'm sorry, this is gonna quit. The specificity, however, is not significantly high in this. Michelle, I'm going to come right back. Ooh. Apology. Michelle, have to have you put the slides up in a second. Let's see what this does. Okay, I'm gonna have you, Michelle, if you can put the slides up and then I can just go through them with you, that would be great. Okay, perfect. So diagnosing this, you want to ensure that they're stable. We went through H&P. I'm going to have you advance to the next slide. And next slide. So basically the FAST exam, especially in pediatrics, they will start with this to try to avoid, if we don't have to do CT for the Alaric concept or the lowest radiation possible. But the specificity is, while specificity is good with 95 to 100%, the sensitivity is quite low. So typically this is not used solely, but I know there has been a push to try to use more FAST exams to imaging. Next slide. And next slide. So this was an interesting paper that was recently, oops, I'm sorry, go back. This was recently released, and this paper and published. It was looking at renal ultrasound to evaluate for renal trauma in children and whether or not how this compared to contrast CT scans. And so 76 patients were retrospectively reviewed. Ultrasound had a sensitivity of 79 to 100% and a negative predictive value of 97 to 100%. This was reviewed by 2 urologists and 2 radiologists. The grade 1 to 2 injuries were the ones that were frequently missed on ultrasound. There was gross hematuria or microhematuria with more than 50 RBCs in all grades 3 to 4 injuries. And the conclusion essentially was it may be sufficient to rule out significant renal trauma, which is what we typically think about with high-grade renal injury. However, also without coexisting injuries in less than 50 RBCs, you miss some lower grade ultrasound imaging of renal injuries. Next slide. So just as a refresher for you all, this is the 2011 AAST grading of renal injuries. So grade 1 is just a subcapsular hematoma and or contusion. Grade 2 is less than 1 centimeter in depth and into the cortex. Grade 3 is greater than 1 centimeter in depth. And grade 4 includes an injury to the collecting system or the vest, which is more for a grade 5. And so this is just a CT imaging of this here. Next slide. So immediate surgical intervention is needed in renal trauma less than 20%. Most of the time you can expectantly manage patients. That said, if they're unstable, or I feel like a lot of us get called in when they're already in the operating room for other injuries with general surgery or pediatric surgery. So 25 to 50 high-grade renal injuries are managed non-operatively. but they still may require intervention. So just because we say expectant management or conservative management does not mean that that's it. They might not need anything. So they have to be closely monitored. So you can do stenting if needed, or nephrostomy drainage if you have worsening extravasation, or if you have a symptomatic urinoma such as a fever, significant pain. And then don't forget about interventional radiology. So we can also do selective embolization if they have a delayed or persistent bleeding from a renal laceration. Next slide. Are you able to hear me now, Michelle?
Yes, we can hear you.
Okay, thank you. So I apologize, everybody. About the absolute indications for exploration. So obviously, if a patient is hemodynamically unstable due to 5 renal vascular, if they have an expanding or pulsatile retroperitoneal hematoma, an inability to stop, obviously, any persistent or delayed hemorrhage by IR, vascular embolization, of which those are going to most likely result in nephrectomy. Next slide. Relative indications could be if you found a retroperitoneal hematoma, and this is usually the time that you get called in by surgery during exploration for other intra-abdominal injuries. So this is controversial whether or not you need to go in there or not. So typically, again, just kind of remember, if it's not pulsatile, then do you really need to go after anything? You can also, that is the time, if they haven't done CT scan, which in this day and age, I can't imagine that they, but you could do, don't forget your single shot IVP to ensure they do have a contralateral kidney. If the CT shows high with other intra-abdominal injuries that they're already going back for, this also is controversial. And I know personally I have gone called in for when there was a liver injury and the retroperitoneum, there was a renal laceration, but there was not a pulsatile hematoma, and we actually did not explore, and the patient did very well. So, because again, that's going to have a high nephrectomy rate. Next. So again, conservative management does not mean leave them and go. So you want to do serial exams, vital signs, obviously, H and urine output, transfuse as needed. It is somewhat controversial as well whether or not they need bed rest until gross hematuria resolves. I know in the pediatric for pediatric surgery and liver injuries, doing less of the bed rest until at this point, but you want to look for any signs of symptomatic urinoma. So flank pain, ileus, or fevers. I often will do prophylactic antibiotics to prevent any of a urinoma. And then it's recommended to do follow-up imaging 48 hours after the initial. It's not necessary that always has to be, but if they were becoming hemodynamically unstable or having worsening symptoms, then you would want to do this. Next slide. So what are the predictors for intervention? So I think there have been a couple of great looking at this specifically. So a perinephric hematoma larger than 2.5 centimeters could be a predictor for intervention. Has been found to be associated with that. Evidence of an active bleed, I do angiography and embolization for this. Lateral extravasation of contrast, no contrast in the distal ipsilateral ureter. This keeps coming up, and I don't know how much this is asked on in-service, but if I had to guess, I bet this would be up significantly, but if you're all fellows, you might not have to worry about that. You could do a retrograde urethrogram, stent placement, or an open exploration. And if you've got medial extravasation of contrast, then you also want to think more about potentially a UPJ obstruction that has ruptured. Next slide. So another group also was looking at grade 4 renal trauma and looked at 17 patients over a 7-year process. Those that ended up failing conservative treatment, meaning they had to go on to some type of intervention, were more likely to have a lack of ipsilateral ureteral contrast, a large separation of the poles, multiple transfusions, and multiple areas of extravasation. There was a 50%, almost 50% intervention rate. Next slide. So this is a patient I actually took care of last year, an 11-year-old boy who had a bike crash. He fell on the handlebars, and he, you can see here on his left kidney, a significant injury pretty much right through the mid-pole of the kidney. Next slide. So I initially managed him conservatively. He did have gross hematuria. He did have a catheter placed, and he was doing well until day 3, and he had a fever. And it literally was right after I gave another talk on trauma at our grand rounds where I had to then go place a stent in this patient. This was one of the more difficult stent placements I have had to do. His pelvis was extremely small, and you can see the extravasation over here in the middle picture as well. But we were able to get a stent in place. Next slide. So after a year, here's his ultrasound, and almost it's interesting how the kidney has healed. You can definitely see the scarring kind of right in the middle of the kidney. His blood pressure has been 120s over 80, so I am sending him urology as well, just to ensure. But he's also on a new medication for ADHD, which could potentially be part of that. So, but I did send him just because of the high grade renal injury and the elevated. Next slide. So don't forget about, again, in pediatrics, so 3 to 5 times more common to have a coexisting or pre-existing in congenital anomaly, such as hydronephrosis or a UPJ disruption. So the vast majority with a history of trauma and the pre-existing UPJ or hydro will have a grade 1 injury because it's usually not the kidney itself, or it's not usually the kidney parenchyma itself. So when you see extravasation, most commonly it's a rupture of the renal pelvis or laceration through the thin cortex, which then obviously can earn you a grade 3. A complete disruption is rare, and there are 3 classic findings on scan. So absence of a parenchymal laceration, medial extravasation in the perirenal and upper ureteral area, and then no visualization of the ipsilateral distal ureter. Next slide. Nephrectomy rates between early surgical intervention and observed was compared in a study by Jacobs, which I thought was very interesting, looking at high-grade renal trauma. So they looked at grade 4 or 5 from the National Trauma Data Bank. And a total of 419 patients they were to look at. And early intervention was more common in grade 5, which I think is what we would all expect at this point. Of the 3% underwent nephrectomy, I was actually surprised that this wasn't higher. In those that were conservatively managed, 11% eventually went on to have a nephrectomy. Most of the injury, the mechanism of injury, as well as the grade, affected the initial treatment decisions. So when you controlled for this, the rate of nephrectomy was still decreased in children that were initially managed conservatively. Again, all pushing towards more conservative management if possible. Next slide. So what kind of follow-up do you need after renal trauma? So I always do an ultrasound before they leave the hospital, because most likely they've had a CT scan, but I want to get an ultrasound because that's typically how I am going to follow them. Now, I don't know if I'm following the rules correctly here, but according to this, all grade 1 and 2 injuries do not need any follow-up imaging. At 3 months post-injury, for grade 3s with viable fragments, they recommend ultrasound. With grade 3 and devitalized fragments, a MRI. And grade 4 and 5, they recommend a CT and MRI. A urine analysis of pressure at 6 and 12 weeks post-injury. And then if you are so concerned, you can, eventually you can get renal scarring, obviously. And if you're concerned for the prognosis of that renal unit, or you've got hypertension, then you can certainly do a renal scan as well. This is where I can say that if they're not having any symptoms on my high grade 3 through 5, I don't always get a CT scan because, again, in pediatrics, we really try to avoid radiation if possible. Next slide. So complications that can happen long-term. So why do we even talk about following up on these patients? But you can have renal vascular hypertension. So usually this will develop within 36 months. If it is sustained, again, this is when you'd want to get your renal scan, what the function is. If it's less than 20% and you're having hypertension, a nephrectomy may be the recommended and best choice. You may need to get an MRI or CT scan, or CT angio to rule out an AV fistula. They could also have a pseudoaneurysm, and these can both be treated with embolization. Also, some patients have chronic flank pain. It's only about 7% in grade 3 or greater. There's usually no specific cause identified, but in a lot of these patients, you can do pain management. You can do a possible nephrectomy. Extremely careful with this. I was always taught to never really operate for pain because you just may not heal the pain. So that is just something I would definitely, they would really have to press me to get to the point. Next slide. Many parents, the first thing they will ask is if they can play football. But this study done in 2007 looked at what are the renal from. We know 90% blunt trauma. We know this. But they found in this study that 45% overwhelmingly was motor vehicle collision. This also included motor vehicle versus pedestrian. Bicycle accidents were 17%, and contact sports were at 12%. So they were the third highest cause. But if you add all-terrain vehicles below that, which is 10%, and you add that to any type of motor vehicle crash, you're already well over half. So again, you're going to get asked this question pretty much every time. Next slide. Most pediatric urologists will clear a patient for one kidney and for contact sports if they have a kidney on the other contralateral side, if they have protective gear, which you can get flank guards. One study looks at the overall risk of renal injury was less than the rate of traumatic brain, head, neck, and spine injury. So actually you have a 3 times higher chance of renal injury from cycling. So it's very important to talk about this. Seatbelts, cars. I always go through ATV and dirt bike accidents, especially the younger the age. I say if you're going to do them, you need to have every type of guard on that you can and protective wear, and obviously a helmet. Next slide. In summary, we need to know exactly what we're dealing with. You can't just watch and wait. You need to do imaging. It's very crucial to know. This is going to dictate how you treat and also predict your outcomes. So you must have delayed imaging. It is extremely common at every place I have ever worked before where the delayed imaging is missed. And fortunately, we have helped our radiologists and trauma teams develop protocols. And we're always very communicative with them that we're happy to be called so we can dictate this. Unfortunately, a lot of these kids come from outside hospitals. And so sometimes you are at the mercy of having to repeat. We try not to if we don't have to. There are absolute and relative indications for renal exploration. The majority of renal injuries expectantly, and 95% of those clinically stable with a grade 4 will not require an open procedure. That doesn't mean endoscopic. And more than 95% will retain a clinically functional kidney. Next slide. So here's my streets. I tell my residents and fellows that I'm sometimes a street urologist. So here's kind of the nitty gritty when you're getting called. Obviously, you've got to do delayed imaging to truly know what you're dealing with. If it is missed, and again, this commonly will happen, hopefully they at least did a CT scan. So one thing you could do is a KUB and just see if you can see extravasation. Always check the UA. Always ask if they have it, if they haven't, or do they have a catheter. Don't forget about IR. You can try to save any and all renal function that you can. The on-the-table IVP, you want to get 1 initially and then at 10 minutes. And at 2 mils per kilogram, again, the in-service loves this question. For an accurate study, though, just remember for pediatrics, your blood pressure has to be systolic greater than 90 for it to even be an accurate study. I always say don't poke the retroperitoneum unless it's at you and is pulsating. And then I also tell parents, if you can play football with 1 brain, then you could probably play football with 1 kidney. However, I often tell them if they're not good at the NFL or be an amazing football player, then maybe find another activity. Next slide. So ureteral injuries, fortunately, are quite rare. And this is in part due to the mobile nature of the ureter. So less than 4% are penetrating. Most of the time you don't see this isolated in a blunt trauma because of those characteristics. It occurs with other abdominal injuries, and so 10% of the time you can see concomitant renal or bladder. What we probably commonly see more frequently is iatrogenic. So from open, laparoscopic, other procedures, endoscopic, ureteroscopy is actually the most common cause of an iatrogenic ureteral injury in the pediatric population. You really need to have a high clinical suspicion. Hematuria is extremely unreliable. And for diagnosis, you'll want to do a delayed imaging CT scan, or you could do a retrograde pyelogram, ureterogram. Next slide. For contusions, if you have a gunshot wound or a crush injury, if you recognize this early, you can stent. You could also do a nephrostomy tube with a staged reconstruction if it's later. If you have a high velocity gunshot wound, you can see tissue necrosis 3 to 5 days later, which then subsequently you'd have to just be wary of the delayed urine leak. And if you're near the ureter and are ready, you could consider stenting. As for iatrogenic, it's very dependent on the location. Proximal, you might need to do a UU versus a ureteral pilostomy. If it's mid, a UU or trans UU, and then distal, you can do a reimplant, and if needed, a psoas hitch and biliary flap if you need to span the distance. Next slide. So my street smarts here is just basically don't forget the ureter. Are they going to the OR? If they are, primarily repair it. If they're going for something else, is it a good time to do a retrograde pyelogram if they have not had any delayed imaging? You want to have maximal drainage as well. So don't forget about a catheter, as that can also help heal. And then consider it in delayed patients. So those with fevers, prolonged ileus, they have persistent pain, if they have a drain, their output is increasing. If they are not able to urinate, or nausea, vomiting, elevated creatinine, all of those things. And you obviously want to ask about previous surgeries. I took care of a child who had a trocar injury directly to his bladder from an appendectomy. And the kid presented extremely sick. He had not voided before he was discharged from the hospital after his surgery, and came back extremely hyponatremic. And you could tell where their incision was for that trocar, that it was right through the bladder. It went through and through. Next slide. So always be suspicious for the lower tract on physical exam. If you see bruising, or if there's a laceration, if they have a pelvic fracture, even with microhematuria, you want to be suspicious. Obviously, gross hematuria, and you've already ruled out the upper tract, and then straddle injuries, which is something more commonly seen in the pediatric population. Next slide. Bladder injuries, fortunately, are rare in pediatrics, and 2% will actually require an intervention in the OR. So it is more susceptible than the adult bladder. There's a higher position in the abdomen, except full. So you are more likely to potentially see intraperitoneal ruptures. There's less muscular protection by the abdominal wall. And then also, once again, typically less pelvic and abdominal fat. Usually this is also not an isolated injury. It's usually with multi-organs. So think of pelvic fractures, which is similar to the adult world. Mortality rate can be as high as 20%, and it's usually from a blunt trauma. Next slide. When you need to image, absolutely. If they have gross hematuria with a pelvic fracture, they're unable to void. Potential reasons, if they're in clot retention, there's a hematoma in the perineum, if there's any history of prior bladder augmentation, I would even maybe move that more up to the absolute. But that is something, again, that you really need to teach your residents and your fellows, especially if they haven't done a lot of pediatrics. Always be thinking about the patients who've had a bladder augmentation. You want to differentiate between intra and extraperitoneal, like in the adult world, because that does affect your management. Next slide. So the best test, obviously, is cystography. And ideally, a CT cystogram is the best imaging. Being said, if you do not have that capability, or if he or she's already had a CT scan elsewhere, and radiology is not really feeling great about doing another CT, which is fine, you can certainly just do a cystography. You'll want to put iodinated contrast, and remember the bladder capacity in kids is age plus 2 times 30 to give you that in mils. You'll want to at least fill into half of the bladder capacity. In kids less than 1, you would use their weight times 7. You want to make sure you get a post-drainage film, an AP, oblique, and lateral. If you do suspect a urethral injury, you can always put an SP tube in as well. In the pediatric world, that typically means going to the OR to put them to sleep if that's the case. Also be wary that a cystogram may not show extravasation if there's a clot. Next slide. Extraperitoneal is the most common, and this is the classic flame sign. If any of you had any bladder perforations during a TURBT, then you may have seen this a time or two. 85% of these are associated with a pelvic fracture, and 10%, but only 10%, unfortunately, of pelvis fractures sustain a lower GU injury. You can also see the teardrop deformity where the pelvic hematoma is compressing the bladder. Next slide. Intraperitoneal is more of a sudden blow to the abdomen or pelvis, and this is what you think when they have a full bladder. Stoma is the weakest part of the bladder. So the cystogram will show outlining of the contrast of the loops of the bowel, and it can be also associated typically with severe intra-abdominal injuries. If you ever are placing a catheter, or if someone put the catheter in and they just never had any urine back, think of this. Next slide. Really what's determining of your treatment is your mechanism. Blunt versus penetrating, also extraperitoneal versus intraperitoneal. I think this pretty much lines up with the adult world as well. If they have a penetrating bladder injury, obviously you've got to go back. If there's an intraperitoneal, you go back. If there's extraperitoneal, but if there's a bladder neck injury, or there's a vaginal or rectal injury, catheter's not draining well, or they're going back for another reason, a bony spicule in the bladder, consider repair of the extraperitoneal at that time as well. Next slide. So again, intravesical classic teaching is all must be surgically explored and repaired. Again, look out for metabolic disturbance, peritonitis. That was the case with my kid. With the trocar injury, you want to do a 2-layer closure and then bring an SP tube through a separate wound, dome, away from the trigone to avoid any fistula places obliquely. Extravesical, again, the degree of extravasation does not really the size. So fully catheter is typically all they need, and an cystogram usually to ensure no extravasation before you pull it. Next slide. If you do not diagnose or control the extravasation initially, you can have very, very serious complications. One study looking at 6-year period from the National Trauma Data Bank, 44% underwent surgery, 67% had intraperitoneal injury, and the pair reduced the likelihood of in-hospital mortality by 82%, which is quite significant. Also, you can think of pelvic abscesses. Patients can get colitis, also continued leakage, and then bladder spasms. Next slide. So always ask about prior surgeries. Ask about any other injuries. So when your consultant calls you or the trauma team, are they going to the OR for any other reason? Has a catheter been placed? How did it go in? Was there urine output? Is there hematuria? How was the bladder imaged? If they've already had a scan, don't forget about your just good old-fashioned cystogram. Next slide. So the pediatric urethra also is fairly well protected. It's because of its shape and its elasticity. You'd also want it though in a pelvic fracture or any significant trauma to the perio. So falling on the bike, things like that, you'll want to kind of keep this in the back of your mind, obviously. And signs that you can have a urethral injury include blood epimetis, gross hematuria, pain during voiding or they're unable to void, and they also may have perineal and scrotal swelling. Next slide. You want a history and physical, and the mechanism once again is important. A DRE, I think in the adult world is certainly something to do. In the pediatric world, I can't say that I've done a lot of DREs just in general, but even in the trauma analysis, but that is something that you're always taught. Urine analysis, and you'll want to get imaging if you have kind of the classic triad of perineal or genital hematoma, blood epimetis, and inability to void. Also think of if you have a fracture of the pubic rami, diastasis, pubic symphysis from a blunt trauma. Boys, you want to do a retrograde urethrogram, and girls, they actually suggest a CT scan and then a potential cystovaginoscopy, especially if they're going back to the OR for any other reason. Next slide. Just like in the adult world, timing of when these injuries or how they should be managed is controversial. Hepatic and membranous urethra, including the urogenital diaphragm, it's the membranous urethra that's most commonly associated with your pelvic trauma. So in 10% of pelvic fractures, and it's usually a distraction injury. These are the complications that, while it seems odd to talk to a patient that's 5 years old or a family of a 5-year-old about stricture and incontinence and erectile dysfunction, it really is something to be considerate of. And you can't really forget that. The timing of repair, again, is controversial. And then anterior is your bulbous and penile urethra. And that's what we commonly see with the straddle injuries. Next slide. Going to immediately treat, you'd want broad spectrum antibiotics. You want to make sure the bladder neck is competent. Urinary drainage, so if you could get a Foley catheter, a lot of time that can be sufficient for a bulbar urethral injury. On females, ideally, if they're stable, you can do an exam under anesthesia and do a primary repair. If they have a more significant injury, such as the bladder neck, you can also see you might have to do some type of proximal diversion to achieve continence eventually. Next slide. So always ask when they call, is there a catheter? Have they voided? What's the urine analysis? If they do need a rug, which this is what I tell my residents, and they may or may not like it, but honestly, I would tell you to do it yourself. The radiology resident, if there is a resident at night, may not know what they've done. They may not know. I have never done one before. If the catheter is already placed, you can do a pericatheter rug alongside of it and get like a 5-inch feeding tube and inject your contrast that way. When in doubt, scope it in. And again, kids, this may need general anesthesia. We are less equipped for the most part, and we don't usually have a cysto cart just roaming around the hospital like we do on the adult side. And then if they're going to the OR for anything else, then it's likely to be safe and scope it in. This patient was, one of my colleagues saw this patient. The kid fell on a pencil and the pencil was removed at the outside hospital, but an exam under anesthesia was performed, and the kid was extremely lucky. Both his rectum and urethra were completely spared. Next slide. Scrotal and testicular trauma is something you certainly see, I feel like, a lot in pediatrics, and you can see penetrating trauma with dog bite. I've seen bullet wounds. You can have, you always want to make sure that the urethra and rectum are not involved. You'll check for, in a dog bite, tetanus, immunization, rabies, status of the animal. Blunt trauma you'll often see as well for sports-related injuries, and you want to make sure that the testes are not involved. So just remember that trauma can mask the true cause of pain, so always kind of have in the back of your mind torsion. I typically, even if it looks like a superficial scrotal lesion, I will still, just to make sure, so I can document as well, everything was fine in the testes. So you'll want to treat with broad spectrum antibiotics, irrigation and debridement, and if needed, you can do a primary closure with drains. If it's a human bite though, close by secondary intention. Next slide. So this is a child that was 8 who fell riding a skateboard. And again, looking at this, clearly looks like superficial, but we went ahead and did an ultrasound as well, and his testes were sure enough fine. This kid was amazing. Allowed us to do this in the emergency room under just local sedation, and we closed that primarily. Next slide. I cannot take credit for this, and this is a picture from one of my colleagues where a child had extremely lucky, but had a hay bale excavator, I think, that tore into the scrotum. The testes were spared. The urethra was injured. I believe the rectum was not, but then this is the closure that they had here. But it's amazing the injuries that we see. Next slide. So think about if you see scrotal ecchymosis or swelling, you can potentially have a hematoma. It could be, you know, and again, sports, athletics. If it's penetrating trauma, look to see what the tissue damage is. They also might have ecchymosis, swelling. 40 to 60% of testicular injuries are penetrating scrotal injuries. Again, H&P, ultrasound. The classic board teaching is for hematocele, you surgically explore. There are some papers that look at conservative management and just watching them. And that certainly, again, if you're going to ask this question on your boards, I would say surgical exploration. Next slide. This is a testicular rupture that I had of a patient who actually had a cup on. He was a catcher, and the ball just hit him in the right spot. He came in about 2 or 3 days later, I believe, and we completely debrided all of the ischemic area, and then we're able to put his testicle back together. Next slide. In pediatrics, you're going to commonly see more blunt penile trauma. You can still see fractures. I actually have seen 2 as an attending in pediatrics. And this can be the same way, sex or masturbation. One child told me he fell out of bed. They can't have an associated urethral injury. So either do a rug or cystoscopy. Since you have to go back anyway, I typically just do a cystoscopy. It can also be from circumcision or other iatrogenic injuries, amputation, electrocautery. In the kids, don't forget about hair tie strangulation. Sometimes if mom's hair gets around the penis, it can mimic a paraphimosis. So you do need to act quickly on that. And then the good old toilet seat and zipper injury is quite prominent as well. Next slide. This child ran into a flagpole while he was playing football, and he was extremely fortunate that it was only dorsally. He had voided for us. His UA was completely no blood. And he was very lucky that this was, again, just a dorsal injury. Next slide. This is a 16-year-old who openly admitted he was having intercourse with his girlfriend, who I found out later when she came to my clinic had a huge cast on her leg. But he had one of the most severe penile fractures I've ever seen. It went through both corpora, and his urethra was
not injured, but it was so close to it, I actually left the catheter in him for a few days. Next slide. Summer penile syndrome is something that you might see, especially if you're in the Midwest. I felt like I saw this more in residency. This can sometimes, usually it's caused by chiggers. And so they'll have redness, swelling, they may have some itching. Usually they can urinate just fine, and oftentimes you can treat with antihistamines and a topical steroid. Next slide. This is a child who was swimming in a creek and had a snake come up and bite him in the penis. And we did put a catheter in to help him urinate, and he got the antivenom and healed very nicely. Next slide. This is, I don't know if there's any Tennessee people on the call. This patient had put a bobby pin through and through. Also lucky that his urethra was not involved. Next slide. This kid, not to discriminate against the West Coast or the East Coast, but this sad patient, unfortunately, is a 17-year-old boy who this is now his third time back to the operating room. This was my lucky time where he had put in this metal chain. And I was about 2 seconds away from just doing an open cystotomy because it was extremely difficult to get this out through his urethra. He'd had already one open cystotomy a few years ago for something he put in, and then another endoscopy for something else. But he was referred to psychiatry. Next slide. If you haven't seen circumcision issues, you will. And as a resident, I was always very nervous because I figured the pediatric residents and OB residents had probably done more than I had. But in the upper left-hand corner, this is a plastibell that wouldn't come off and had to be cut off. And then moving the next step over would be a patient who had a dorsal slit and then the meatus was cut. So that is something that can very easily happen. And then the patient had a moil circumcision, a routine ritual circumcision, and had the glands excised. This was put back on in place by urology and plastic surgery, and the patient is reported to be having good erections. The picture down below is something that was very frightening. It was a newborn circumcision that was injected with 1 cc of lidocaine with epinephrine. So he actually was transferred from the outside hospital, and nitro paste was put on the area and observed. And a few days later, he was doing fantastic. Next slide. So always get an ultrasound on the scrotum. Even if it's just superficial, it's just going to make you feel better, and it's going to be able to cover everything and ensure that everything in the testes. Make sure you clean the wound copiously. Don't assume the ED will. There's nothing worse than seeing a patient the next day if they're admitted overnight and they still have dried blood everywhere. So even pediatric patients can have penile fractures. And when in doubt, if peds or OB is doing the circumcision and they call, just tell them to stop. Next slide. So overall, there is some unique differences between pediatric and adult trauma. You still want to do, though, a timely and accurate diagnosis. Most renal trauma is managed expectantly. Also have a high suspicion of bladder neck injuries and pelvic fractures, similar to the adult world. And then oftentimes multiple organs can be affected. Next slide. And now I will take a look at the questions and comments. And I'm going to try to do this, guys. I really apologize for the technical difficulties. So if you can use this little app here for the survey. You guys probably all know this by now. Let's see if there's anything on the chat. Or some of the chat during my technical difficulties, but it doesn't look like there's any questions. So with that, I will, if there's no questions out there, I'll leave this as is. Again, I apologize for the technical difficulties. And if you have any questions, please feel free to email me anytime. Thank you.